Hey YouTube, and welcome to another edition of the Nurse Lounge. In today's edition, we're going to talk about what I do as a OB/GYN nurse. So for those who don't know, I work in obstetrics and gynecology, and I also work in well baby nursery. So let me tell you about what that life is like. So basically, I work at a hospital still, PRN, but I work there probably about 3 to 4 shifts per month. And I work primarily on postpartum. So postpartum is where you come to after you have your baby. So it's basically like a specialized med surge, if you think about it, because there's only women on our floor, and we see women who obviously have just had babies. So our patient population ranges from age of, I've seen them as young as 12, believe it or not. And I've had a patient as old as, I want to say 49, something like that. So we have relatively young women in the general scheme of things in terms of the lifespan. 49 is still on the younger side. But as you should know, or if you don't know, women or girls have their eggs from birth. So therefore, 40 and over 35 is considered to be advanced maternal age. So therefore, if you're having a baby after the age of 35 or 35 and older, you're considered to be old because your eggs are old. You've had them all your life. So with that being said, that's kind of what I do. So what is a typical day like for me? So when I go into work, I have to be there at 6:45 in the morning, and I get report from the night shift nurse. I do work days, so I get report from the night shift nurse, and I get my patient assignment. So I happened to just work yesterday. So I worked yesterday, which was the 3rd of January, and I had 5 patients. Our typical ratio is 1 nurse has about 6 patients, but I had 5. And I had, everyone had had babies except for one. She had had a baby a few days back, but she came in for another issue. So I had to see her, take care of her as well. And again, of course, all our patients are female because they have all had children. On the other side of that, we do gynecology, which means any female type issue that you may have. So if you've had a bladder prolapse, or you want to get your tubes tied, or you've had a uterine prolapse, even cervical prolapse, the doctors will put all that back in there, and you have to stay in the hospital for a day or two, and we take care of you as well, so on our floor. So I basically come in and I see my patients. In the morning, I will get report. I go look up all my medications to see who I need to give to what, when, and that way I can determine who I need to see first based off of that. And believe it or not, I actually take time to go eat breakfast. So I'll go eat breakfast between usually 7 and 7:30, and then start my rounds between 7:30 and 8 in the morning. So after I do that, I go see my patients, and I get their vital signs and get their medications passed. And I do their head-to-toe assessments. And yes, we have to do head-to-toe assessments on all our patients, even though it's OB. Then after I do that, pass their meds, I actually start charting. Now, it may take me 15 minutes or so to see each patient, but it takes me about 2 hours, believe it or not, to chart total, because there's so much to chart that we have to chart to make sure that it's accurate and things like that. Plus I have to stop and sometimes get pain medication or follow up on pain and things of that nature. So that's kind of what I do. By lunchtime, we're working on getting patients discharged. So people who are going home that day, we have a discharge class for them. So we send them to the class, and they teach them everything they need to know about how to care for themselves and the baby. And then we work on getting them discharged home. Meantime, I'm getting new patients in. So I'm getting new patients, I'm maintaining the ones I have, plus I am sending some home. And that's typically how the flow goes every day. Now, my hospital is not a mother-baby unit, which means one nurse has a mom and her baby. Our hospital still has a nursery, a well-baby nursery, and we actually have postpartum. So we have nursery nurses and we have postpartum nurses. So I take care of mom, and the nursery nurse takes care of the baby. But some hospitals have what's called couplet care, where they take care of both together. We do not have that yet, but that's the plan going forward. Eventually is to have couplet care, but for now we're separate. Personally, I like it better that way, but it is what it is when it comes to couplet care. So after I do all that, then I'm just pretty much maintaining my patients throughout the shift, checking on them, making sure that they don't have any needs, making sure they're not in any pain, making sure that they don't need to be toileted. And believe it or not, we have to tell people to go to the bathroom after having a baby. We have to remind them to go to the bathroom. We do a lot of education. So we're teaching them about how to keep themselves clean after having a baby, how to feed the baby. When I do get floated, which means you have to get sent to another unit to work, I get floated usually to nursery. So I'll go work in Well Baby Nursery. And so I take care of the babies that day. I don't take care of the moms, but I take care of babies. And so in that role, I basically do assessments on the babies. We help with circumcisions. We help with breastfeeding. We help with mom teaching her how to even change the baby's diaper, how to get the baby dressed, and basically how to do basic care for a newborn baby and what to kind of watch out for, as well as keeping herself healthy as well. So what are my patients like? That's what people want to know sometimes. What are my patients like in OB? So keep in mind they're young typically. So if we have a mom who is, let's say, 20 years old and she's having her first baby, believe it or not, a lot of 20-year-olds actually rely on their own mothers or support person to come and help them. So we have to kind of include the family in our teaching and our care, and kind of dispelling myths about things such as, oh, there used to be a pill to help dry up breast milk. Well, they don't have that no more. You have to either pump or breastfeed, or you're going to not do that, and therefore your milk will eventually come in and then dry up at some point. So we have to teach patients that because their mothers or grandmothers have taught them something different, or something that's happened, you know, maybe 30 years ago or 40 years ago, before, obviously before their time. So we just kind of have to teach them and kind of, you know, about what's right, what's wrong when it comes to taking care of themselves and their babies. After all that is done, then we have to call the doctors and update them on things that's going on with their patient per their request. We have to send labs down and kind of evaluate based on the results of those labs what interventions have to be done for our patients. Some patients lose too much blood after giving birth, so we have to give blood to them if they happen to need it. Our patients are typically very tired. As you can imagine, if you have been in labor for some people up to 3 days, they're going to be tired after they have their baby. So sometimes they don't want to be bothered. However, as a nurse who is managing their care, I'm required to go in and see them every hour during the day and every 2 hours at night. So that's kind of how it works. So students that I have, because I'm also a nurse educator, students that I have who go to clinical with me, they'll say, well, you know, these people are healthy. And compared to the general population of patients, yes, they typically are. They typically don't have all your comorbidities such as hypertension and diabetes and things like that. However, I happen to work with a high-risk population, and so my population does have those risk factors. We do have a lot of people with diabetes and a lot of people with hypertension that I have to care for. And so therefore, when it comes to taking care of them, the caring for them as well as taking care of them postpartum, in addition to their disease process, makes them a much more complicated patient, trying to maintain and manage their diabetes, manage their hypertension, and make sure they're taking their medication as they should, or administer insulin if I have to administer insulin. So on our floor as well, we have photographers that come and take care of, not take care of anybody. They take pictures, sorry. They take pictures of the babies. We have a guy who comes and does hearing screens on those babies to make sure they can hear. We do car seat tests on the babies who are born a little bit early, just to make sure they're going to be able to sit in a car seat for the travel home. We do encourage breastfeeding at our facility. We have 2 lactation consultants that come by and see the patients and make sure they get help that they need in breastfeeding. We also have someone from, I don't know what they call them, but they're basically like a Healthy Start program that they come see new mothers just to make sure they're not going to need help when they go home. So we do have a program for them as well. So if they need extra help at home and they want to learn more about how to take care of their child and understand proper growth and development and those babies meeting their milestones, we do have a program that we refer them to for that as well. So that's pretty much what I do. The students often ask me, well, when it comes to these patient populations, they don't want to wake them up because, they just had the baby and they're just kind of tired. So when we go in the mornings, when I have students, they'll say, well, I didn't want to wake them up. They were sleeping. They, just had their baby. And I have to remind them that we are nurses, or we're going to school to be nurses. In their situation, that's my other job, to be a nurse educator, clinical educator. So when I have students with me at work, then that's kind of what we do. And I have to kind of tell them, oh no, you have to go wake them up because you have an assessment to do. If that doctor comes in and says, what is going on with Miss Such and Such? Well, the only thing you can tell the doctor is that she's been sleeping. That's not going to be sufficient. And he or she's going to be very upset that you have not did your assessment and it's noon. So we have to sometimes take off our mama hats and put on our nurse hats, and make sure that we're taking care of our patients. So what is the personality of some of these patients that you have in OB? Well, a lot of them are young, they're teenagers. So if you think about Erickson's stages, what are teenagers kind of going through? If you think about someone in their 20s to 30s, what are they going through? And then in addition to that, somebody in their 40s, what are they going through? Sometimes this baby was an oops baby that wasn't expected. Sometimes people have had babies after they had a tubal ligation. So they got their tubes tied and they didn't think they could have babies anymore. And so here this baby comes and they're like, oh my gosh, I'm shocked, So they're kind of in their own world about trying to figure out, what do we do? We're starting over again with this new baby. We have lesbian couples who come in and they have babies. We have surrogates where a lady will carry the baby for the pregnancy and then turn the baby over to the biological parents in this case, where basically the egg and sperm were united and implanted in the surrogate. She carried the baby, she delivered the baby, and then handed the baby over to the parents. We have, so we talked about lesbian couples. Of course, we have gay couples, so two men and they have babies. Now, obviously, two men can't have babies. They have to have a surrogate, but I'm just saying as a family unit, that is what they are. We have people who I have seen who, I saw a guy 1 week with a certain female and they had a baby, and then I turn around and see him again the following week with another female because he had a baby with that person too. So we see all kinds of things in OB. Also, unfortunately, we see a lot of drugs. And I don't see much alcohol abuse, but I do see a lot of drug abuse in OB. And I'm the one who has to call DCS to say, hey, mom is positive for some type of drug, And if the baby comes up positive, we have case management involved and they have to decide whether that mom is going to be able to take her baby home with her or not. So I have to deal with all those things in my nursing world. So it's very, very different than med-surg is. Med-surg is where you truly have sick people typically, and they're coming in to get better from that disease process. Whereas OB is a world where you're relatively healthy usually. You're coming in strictly to have a baby, and then once you get through the first 2 or 3 days, then you go home. Now, when it comes to having a baby, most people know that you have a baby one of 2 ways. So you're either going to have the baby vaginally or you're going to have a cesarean section. So a cesarean section is a surgery, an abdominal surgery in which they cut you, not literally hip to hip, but they cut you in a lower abdominal incision, and they basically cut the uterus and they take the baby out that way. Or of course the natural way is vaginally, which is how it's preferred to have babies. So we have to take care of surgery patients as well. So C-sections or surgery patients. We have gynecological surgery patients, and then we have our vaginal delivery patients. So in OB, people think OB is such a happy place. Well, most of the time it is, but it's not always what you think when it comes to your people who are happy, who they planned this pregnancy. Sometimes it's your teen moms. Sometimes it's your rape victims. Sometimes it's where we've had people who are mentally challenged, who have been taken advantage of, and they got pregnant. Sometimes it's your jail moms where she went to jail pregnant and now it's time to deliver. So she's come to the hospital with shackles on and deliver shackled to a bed with her guards present. So there's not the sense of privacy and intimacy that you would expect. And typically they can't even see or hold their babies after the fact at our facility. Now, if your facility does something different, then, you can go ahead and speak to that in the comments below. But our facility, that's how it is. And again, the things that I'm telling you is what it's like at our facility. Do not take this as a generalization, as if this is how every OB unit works, as how every nurse works, as if how every state even works. That's not the case at all. So it can vary based off of your state policies and laws. It varies based off of your hospital policies, and then also your doctor's orders, because what doctors do and don't do are just as individual as the doctor themselves. So be mindful of those things. That's kind of what we deal with in OB. Again, drugs, alcohol, people who are homeless. We've had people who literally had no place to go after they left the hospital. And I've had people where they could not take their 6 weeks off after delivery. So typically after you have a baby, you take your 6 weeks off postpartum so you don't work, so that you can heal and recover and bond with your baby and adjust to the new addition to the house. But we've had people who've had to literally leave their babies at the hospital, sign themselves out AMA, which is against medical advice, and go to work. Otherwise, they would lose their job. That's how serious it is for some people. It's not the same situation for everybody where they can just take off and have a great, experience and recover and bond with their baby and bond with their significant other, bringing this new baby into the house. Or if there's other siblings, bring that into the situation. You don't realize how many babies get taken away from moms because they have did something they should not have been doing. Or how many people who mom wants to be the best mom she can be, but she has a drug addiction, and she, is in the process of rehab and she needs help. We see things like that. So it's not what you think when you're thinking about, oh, these two people just come and have their baby and they live happily ever after. Far from it. That we do have that, but it's far from it otherwise. Excuse me. So hopefully I've provided you a little bit of insight in terms of what it's like in the OB world. I'm just as busy on my floor as a med-surg nurse is on his or her floor. In terms of what the myths are out there from other nurses, they feel that, OB is really one of those cush areas where we really don't do anything, but it's far from the truth. There's hard work on every unit. So I could not go to med-surg and work the way they work. Med-surg nurses could not come to my floor and work the way we work. For one, my floor, we don't have techs. So if we don't have techs or CNAs or PCTs or whatever you all call them, guess who has to do everything? So when I have to go get my patient up, my C-section up, it's me who has to do that. When it comes to cleaning my C-sections, guess what? For the first 12 hours, our C-sections don't get out of the bed. So when they're bleeding, guess who has to clean that up? Me, the nurse. Guess who empties the Foleys? Me. Guess who cleans the vomit? Me. So with that being said, understand that on med-surg floors, they typically have techs on their floors. The techs who help assist get patients up, do their vital signs for them. Oh, I do vital signs too. So I have to do it all. And I'll have 6 or 7 patients, or no, not 7, but 6 patients. And I have to do all this work. And I'm not complaining. I'm just saying that's just kind of how the nature of my floor is. We don't have techs, and we have tried to get techs, but we cannot get techs because they're not wanting to put money into that. So the nurse has to do it all. Now keep in mind, I have GYN patients, C-section patients, and vaginal delivery patients all on one floor. So the acuity, which is how much time it needs to care for them, can be high. So if I have someone who just delivered today, and all 6 patients just delivered today, my acuity is very high because they're all requiring more frequent rounding and more frequent care, more frequent medication. Whereas someone who had their baby 2 days ago, she won't require as much care typically. So therefore, the acuity is lower with that patient, but it just depends on the kind of day that you have. Also on our unit, we do we don't have a secretary on night shift. Now I do work days, but at nights we have no secretary. So guess what? We have a locked unit to prevent anybody from just walking into our floor to protect our babies. So when we have the phone ring because somebody's coming to visit, this nurse has to stop what she's doing and go answer the phone and go say, you know, ask who it is and who they're here to see before she can let them in. And then she goes back to doing what she was doing. So imagine coming in and the phone's steadily ringing and ringing and ringing and you can't see your patients. So then our patients are upset because their care is delayed. I asked for that spray 20 minutes ago. And they probably did. But the thing is, because we're doing other things that are more urgent, the Sprite had to wait and we have nobody to take it to them but us. So my job as an OB nurse is very, very difficult, time consuming. It's a process in which you have to love. I do love being an OB nurse. I don't care for some of the politics that we have at our facility. However, you know, I love what I do and I do not want to do any other kind of nursing. I knew in nursing school that OB is what I wanted to do. And I knew that back when I was pregnant with my second child and she had to go to the NICU. I was like, you know what, this is what I want to do. I want to be a nurse and I want to work in this area. I don't do NICU, but I do take care of the moms and the well babies and, you know, GYN surgeries. So hopefully this has been insightful for you about what my world is like in OB. If you have any questions or anything you want to know more specifically about OB, go ahead and leave the comments down below or ask the questions below and I'll be happy to answer them for you. As always, subscribe. Hit that notification bell so you know the next time that I upload and you don't miss a video. Until the next time, take care. Bye-bye.